Yep, so CNS bacterial infections. And the things that we'll hopefully talk about over the next sort of 45 minutes an hour is types of bacteria causing meningitis, the commonest pathogens that we would tend to see, pathophysiology, so how meningitis can develop, what you might see in terms of presenting features, and then how do we treat meningitis, depending on which pathogen we have. So to start off with, when we're thinking about bacteria, we want to classify them with how they stain, so gram-positive versus gram-negative. And we can see that the gram-positive bacteria have got a thick peptidoglycan sort of cell wall, which absorbs the dye, so they stay purple when they're stained. And that would be things like staph and strep. And then gram-negative, the dye washes off and it leaves a sort of pink colour. And that would be things like E. coli, Haemophilus influenzae, Meningococcus, Pseudomonas. The gram-negative bacteria also have lipopolysaccharides, so little proteins on the cell wall, and those are the things that induce an inflammatory response. So this is often why people who have meningococcal or Hib meningitis can often have more severe sequelae because they might have a bigger inflammatory response to the bacteria. And I've just classified the sort of top causes of meningitis and done it by age group because it differs over time. And I've coloured them in depending on whether they're gram-positive or gram-negative. So in the neonatal period, worldwide, probably group B strep is the most common cause, which is gram-positive, but followed by E. coli. And then strep pneumoniae and listeria are slightly less common. And then babies and young children, so sort of 3 months onwards, strep pneumoniae worldwide would be the most common one. And then Neisseria meningitidis and Haemophilus influenzae would be the sort of next most likely causes. Occasionally, you can have group B strep over 3 months, but that would be really late onset disease. It's usually a neonatal and in the first 3 months of life issue. And then TB meningitis would be another consideration in that age group. And then in older children, we'd have meningococcal and strep pneumoniae. And I've just put this is the UK vaccination schedule, which just outlines, when we're thinking about the vaccines and thinking about meningitis, we're quite lucky that we've actually managed to really reduce the incidence of meningococcal disease and Hib meningitis with a vaccination program. And I think, in actual fact, I had a look at your local immunisation schedule as well, and it's broadly similar, although I know obviously coverage will be incredibly low at the moment. So you may be seeing outbreaks due to these vaccine-related diseases. So we would want to get protection at the time that you're most likely to get infection with this kind of bacteria. So thinking about Hib, Haemophilus influenza, you're getting that early on in your vaccine schedule, and same for Men B. And then meningitis C. We often see peaks of that in sort of teenagers or older children. So you do have some protection against meningitis C when you're about 1 year, but actually the big sort of risk period is when you're a sort of teenager, university age, and often for people going for Hajj as well. So we want to vaccinate you when you're a little bit older. And then pneumococcal, again, that can cause disease when you're in the younger age group. So we want to get your protection in early. So that's quite early on in the schedule. And BCG, not the best vaccine in terms of preventing TB overall, but it is very effective in preventing TB meningitis. So getting that in at birth is really important. And then just thinking more now along the lines of the pathogenesis of meningitis. So how do we transmit these pathogens? Group B strep and E. coli, that transmission could occur during delivery, so from spread within the genital tract. Haemophilus influenzae, strep pneumoniae, and TB, they're droplet spread. And Neisseria meningitis, but just as so meningococcal is like a household contact, so we'd call it a kissing contact, so respiratory secretions and really close contact. And listeria is through contaminated food, and that can often infect either some people at the very extremes of age, so it could be transmitted via mum for neonate or could be in elderly population. And TB is droplet spread, so people with active pulmonary disease. And I've put in brackets here, E. coli can also be transmitted fecal-orally, but the likelihood is it's going to be causing meningitis in a neonate, and that would be spread via mum. So yeah, pathogenesis. So this is of the pathogenesis for the five most common causes of meningitis. It's similar for all of these causes. So the first thing that you need is the colonization of whichever tract you're looking at. So is it the GI tract, respiratory tract, or the genital tract in the case of group B strep, for example. The bacteria have pili or fimbriae, which are these projections that you can see in the picture there that they use to attach to cells. They might be able to secrete enzymes to evade the host defenses, so they're not excreted. And then they can invade either into or between the cells. And those bacteria that have a capsule may be able to evade the immune system as well. That can also help with this process. And then the next stage, once you've invaded your cell, is getting into the bloodstream. So what we know that colonization doesn't necessarily lead to invasion. We know that a lot of people carry different strains of um, Neisseria meningitis without having disease. So, it can be there and not be causing disease. The invasiveness relates to lots of different interactions. So it could be the environment. So have you had a recent viral infection? Is your nasal mucosa damaged, and then bacteria more easily going to get in. Similarly, smoking or alcohol use could lead you to have a more damaged mucosa. And then is it an issue with the host? So people who don't have a spleen or who have antibody deficiency or on immunosuppressants are more likely to have invasive disease because their defenses are lower. And then genetic factors. So is it someone who's got a genetic condition that means they're less able to fight infections, or is this a particularly virulent or invasive strain of bacteria? So genetics in both the host and the bacteria could mean the difference between invading and not invading. And then once you've invaded the bloodstream, you obviously need to survive within the bloodstream. So this is where your gram-positive bacteria, your polysaccharide capsule comes into play. So it can help protect the bacteria from the immune response by avoiding certain proteins binding to the bacteria. So that might prevent phagocytosis or antibody dependent killing. And then some bacteria are also quite sneaky and secrete proteins that can activate bits of the immune response as well. And then once you've survived intravascularly, you need to get into the CSF basically, and so meningeal invasion. So crossing the blood-brain barrier depends on how long you're bacteremic for and how bacteremic you are. So if you have a prolonged bacteremia and or a high amount of bacteria in the bloodstream, you're much more likely to have invasion into the CSF. So what happens here is the bacteria sort of bind into the endothelial cells. So this is, as you're getting into the capillaries here in the brain, it's very, very thin walled. So binding to the cells, disrupt this gap between the cells and get across the blood-brain barrier into the CSF. And then once you're in the CSF, there are lots fewer immune proteins, so lots fewer things to prevent the bacteria from multiplying. So they can quite happily multiply there in the CSF. The presence of the bacteria leads to inflammation. White blood cells will travel to fight infection, and you get more inflammation. And it's this, not the presence of the bacteria alone, but it's this inflammatory response which leads to the neurological damage that you get post-infection. So does anyone have any suggestions just in terms of what you might be expecting to see in terms of clinical presentation? So what features would worry you in the history or examination for a child that you're concerned might have meningitis?
Yeah, like it mainly depends on the age, but its fever is very important. And
Yeah,
poor feeding, especially for neonates and
yeah.
young children.
Yeah, no, and that's really important, isn't it? Because babies and very young children are not going to be able to give you very clear signs of meningism. So it just could be as simple as they've got a fever, they're not feeding, or they're vomiting. Just something's not quite right. So yeah, that's really key. Anything that let's say a child who's able to talk might tell you is wrong. So we might see things like headache, saying that they've got a stiff neck or that the light is troubling them, so photophobia, and then general sort of systemic symptoms, so nausea, vomiting, diarrhea, just lethargy, achiness. In babies as well, irritability, so just will not settle, just constantly crying, or even seizures. And then examination wise, um, again, it's much less specific in babies. They might just be drowsy and irritable or a bit floppy. Older children might be just less active than usual. In terms of signs and symptoms, they might have tachycardia, they might have a low blood pressure, which is quite a late sign of being unwell in children. That's really worrying because babies and children are really good at compensating with tachycardia before they get to the point that their blood pressure drops. So that's really quite a late sign. Um, poor perfusion, meningococcal disease, we can see purpura. And in other causes of DIC, so if you had an overwhelming bacterial infection, even not with meningococcal disease, you could see purpura. And then Koenig and Brzezinski's signs. Oh, so this is purpura in the pictures there, and Koenig and Brzezinski's signs. So this is pain on in the neck on flexing the knee, and then if you Brzezinski signs, if you flex the neck, you involuntarily get hip and knee flexion. And in babies as well, if you've got a fontanelle, it's going to be bulging. Any thoughts on what investigations might be helpful to diagnose or figure out what's going on in terms of meningitis?
Yeah, it should be ruled out by the full septic uh, exam, like
Mhm.
the CBC first,
Mhm.
CRP we can use, and also urine analysis, urine culture,
Yeah,
blood culture, and LP.
yeah, fantastic. So making sure you get samples from all your systems where possible. Um, Other things that could be helpful, a blood gas, it might have a raised lactate, so that could be a sign of like circulatory failure. Um, And then clotting, I guess if you see purpura, that's going to make you worry about your clotting. So something else that you could check. Some I in the UK, there's a suggestion that if, for example, someone's presenting to not hospital, so to the general practitioner, and they're worried that that child might have meningitis, they could give them an intramuscular dose of penicillin, at which point you're not going to grow anything in your blood cultures. So you might want to do a PCR for meningococcal disease or pneumococcal disease. I think both are available. And then, yeah, but as soon as possible, you do want to try and get that lumbar puncture done to confirm your diagnosis. So lumbar punctures are tricky to interpret. I work in the infection team here, and we often get questions about interpreting lumbar punctures because, the tap doesn't always go well. Sometimes there's blood stains. It can be tricky to interpret. So I guess a few suggestions here on what might be normal findings and what might be worrying things. So the amount of white cells in your CSF does vary over age. So under 1 month, it is possible to see up to around 20 white blood cells, and that should really be lymphocytes in the CSF, and that can be normal. Those children have also a generally higher protein, but you'd expect it to be under 1 gram per litre. And you'd still expect to have about 2/3 of CSF glucose to blood ratio. So, yeah, so around about 2/3 or an absolute value of more than two. You then over 1 month, it is really abnormal to have cells in the CSF in a well child. So there should definitely be less than 5, but really probably 0. And a lower protein, and still you should have about 2/3 of the amount of glucose in the CSF that you have in the blood. And the other thing, I guess, is if you're catching someone with meningitis early on, you might not see that abnormal CSF finding. So I guess it is possible to have a relatively normal CSF findings in a child who does have meningitis. So I think if in any doubt, treat the child until you have, let's say, for example, your CSF cultures or your blood cultures back. And then just going through the different pathogens that we might find causing meningitis, and what you might see in the CSF. So a bacterial meningitis, you're going to expect to see a predominance of neutrophils um, rather than lymphocytes. You're going to see an elevated protein, and you're going to see a lower glucose. But with the caveat that sometimes, if you catch this disease early, you might see normal findings in some cases. In viral meningitis, you're probably not going to see as many neutrophils. You're going to see lymphocytes. Um, Maybe a slightly elevated protein, but maybe normal. And usually the glucose value is normal. And then in TB meningitis, that is interestingly usually predominantly lymphocytes as well, and a really high protein and a really low glucose. It's and then the other thing that we do when we're sort of counting the cells in the CSF, the lab will be doing a gram stain as well, and you may have so few bacteria in the CSF that you may have a negative gram stain. You may not actually see the bacteria under the microscope. You may have to wait till you get your culture to get your diagnosis. And in viral meningitis, we see a lot of enteroviral meningitis. Here, you often actually get quite a few neutrophils before it becomes lymphocytic CSF. So, depending on when you've done that LP, you might have slightly confusing findings. If you're unsure if the CSF is abnormal, the safest course is to treat for bacterial meningitis. That's the thing that you don't really want to miss. We also have the BioFire panel. So it's a PCR panel which has all of the commonest pathogens. So both things which are viral, including things like herpes and chickenpox, but also bacterial. So like your Group B strep, your E. coli. So if the child has had antibiotics before you've seen them, that can be really helpful because you're probably not going to have positive culture, but you might be able to detect on PCR. And then what are we going to treat with? What are our optimal antibiotics for different bacteria? So general rules, and this it is specific to the UK. In some settings, you may have some different resistance patterns, but overall, these would probably be the most appropriate antibiotics, I would suspect. Group B strep is always going to be penicillin sensitive, so you're going to treat with benzyl penicillin. And usually in the initial phase, the first couple of days while a baby's unwell, you might have gentamicin as well, with a total treatment course of 14 days. E. coli is a more prolonged treatment course to prevent the risk of relapse. And that would usually be if you're in a setting where there's low cephalosporin resistance, you want a cephalosporin that would go into the CSF, so something like cefotaxime or ceftriaxone. Listeria is amoxicillin sensitive. So once you've established that, you will treat with amoxicillin. And again, this is what you're going to see in neonates, and usually the initial antibiotics that you give to neonates also contains aminoglycoside, so gentamicin, for example. And that's a prolonged treatment course of 21 days. Strep pneumoniae, another cephalosporin, 10 days, and Haemophilus influenzae, cephalosporin again, 7 to 10 days. And Neisseria meningitidis, interesting, even though it causes severe disease, in actual fact, the bacteria itself is quite easy to eradicate. So usually a 7-day treatment course is adequate. The children who have meningococcal disease, like I was saying, it's often the inflammatory response which is responsible for a lot of their neurological issues down the line. And TB, so you're going to give quadruple treatment in the initial phase and then move down to just rifampicin and isoniazid. And that's a total of 9 to 12 months, so really prolonged treatment there. And then the other question comes, if you have someone in the household who has meningitis, are there others at home who are at risk? So with Neisseria meningitidis and Haemophilus influenzae, you do want to give prophylaxis to other household contacts, and that can be either ciprofloxacin or rifampicin or ceftriaxone, once those household contacts are identified. And the other thing that we think about when we think about improving outcomes of meningitis, obviously getting your antibiotics in early, but the other thing is we often think about, should we be giving steroids? And I'm not sure what you've seen in your practice, but often I think we struggle to make our diagnosis quickly enough to do this. Our national body, which gives overall guidance about what we should be doing, suggests that if you have suspected or confirmed bacterial meningitis, you want to give steroids if you've got any of these characteristics on your lumbar puncture. So if you see pus, really high white cell count, really high protein, or visible bacteria on the gram stain. But the window in which you can give the steroids is that when it actually has a benefit is really narrow. So you either want to give it before or with the first dose of antibiotics, or within the next 4 hours. Don't wait and start it later. So to actually get that diagnosis, you know, often you've given the antibiotics, then you've managed to get the lumbar puncture. So it's a little bit down the line before you actually get to thinking about whether or not you give steroids. So we're generally not brilliant at getting those in early. And I guess, does it matter? Why do we want to give steroids? What are the outcomes when we give steroids? And it's really very specific to Haemophilus influenzae, to Hib meningitis. There's a proven reduction in the risk of hearing loss post meningitis, and that timing was really give it straight away with the first dose of antibiotics. It's not clear for other pathogens, so the evidence about giving with strep pneumoniae is unclear. And also in terms of age, giving under 3 months was inconclusive as to whether there's any benefit. The one other pathogen where there is a very, very clear benefit is TB meningitis. So in all patients who've got TB meningitis, they start off with dexamethasone and then have a weaning course of prednisolone. So they can even be on steroids for up to 8 weeks in terms of wanting to reduce that inflammatory response by giving steroids. And it has been shown to reduce mortality. In patients with both HIV and TB meningitis, we would start treating the TB first and delay starting antiretrovirals if this is a new diagnosis, because once you have reconstitution of the immune system, you can get an inflammatory response and then you could worsen your CNS inflammation. And so that's it on meningitis from me. Does anyone have any questions or thoughts? Let me see if I can bring the screen back up. There we go. Oh, sorry. There have been some comments in the chat. Thank you. Sorry, I couldn't see those, but yeah, I absolutely agree. Confusion, seizures, irritability, perfect signs of raised intracranial pressure. Exactly. Wanting to get the lumbar puncture, getting cultures done. Yeah, fantastic. I have done some
Thank you so much,
questions.
Dr.
Oh, you're
Emily.
very, very welcome. I have done some questions that go alongside the lecture. Hopefully, I should have covered what is in the answers to the question in the lecture. So hopefully it'll be a good test of whether I managed to do that and whether you can recall the content of the lecture if you want to go back and think about it later on. So hopefully those can be circulated to you. And I've also given a PDF of the slides in case those would be helpful if you wanted to go back and have a look at it later on. Is there anything else that would be helpful to cover this morning? I do have a few other bits and pieces about, for example, rashes or other clinical cases. So if you have time or wish to do anything, I'm very happy to. Otherwise, I'll let you go. Oh, and thank you for the messages in the chat. Very welcome. And if you do have, we can do rashes if possible. Yep, no problem. Just give me a moment to find my. Let me stop sharing for a moment. I'll just find my lectures. Okay. I have found some. It's a sort of a bit of background on rashes and then a couple of clinical cases. So we can just go for as long as you're finding it interesting, and we'll see how we go. So let me just share my screen again. Um, I'm sorry, I now can't see the chat when I'm lecturing. I can try it and just turn my big screen back on and just see, because I appreciate that the people who are contributing in the chat are then missing out. Let me try popping that back on this screen. Has that gone into the mode where you can just see the presenter view again? Or are you seeing the proper version? Is it just small slides that you can see?
Yes, we can see the small slides.
The small version, okay. Just try moving that up there. How about now? Is that better?
Yes, we can see the full
That
screen now.
big version. Okay, brilliant. I still can't now see the chat. So maybe if there are things that people do put in, would it be okay if anyone does have access to a microphone just to shout out if there's questions or anything as we go? Um, so I'll just start off and like I say, interrupt me whenever you want to stop. I can again I can send this as a PDF if it's interesting to do the sort of case practices later on. So when we're thinking about rashes, I always find it tricky to describe rashes, particularly if you're wanting to speak to dermatology colleagues and ask them they think is going on. Um, so I guess going over just what terminology we have for different um, bits of rash. So when we're thinking macule, and we're thinking an area of change in the skin color, it's not elevated, it's not depressed, it's and it can be any size. So here's an example of a cafe au lait macule, which you can get with neurofibromatosis, and some hypopigmented areas. So those are flat but lot of pigment. And then a papule is a solid raised lesion up to about 0.5 centimeter in diameter. So often, children, when they have a virus, they have a macular papular rash. They have some flat bits and some raised bits. And a nodule is similar in terms of size, but maybe sort of feels like it's deeper in the skin. And nappy dermatitis is just an example of a rash that you might see that's sort of papular. And then thinking about a plaque, so that's an elevation of the skin again, but it's a very large area in relation to its height. So you could have a bunch of papules that have stuck together to form a plaque. And an example of something that gives you a plaque would be psoriasis. And then a pustule, so a circumscribed elevation of skin which contains pus. That might be erythema toxicum. So in neonates, you can get a really normal rash, which looks quite dramatic, of just little pustules that appear, and that's normal. They sort of come and go over the first weeks of life. A vesicle, so another elevated fluid containing lesion, but that's a small lesion and sort of thinner fluid than a pustule. And a bulla is kind of like a vesicle except big. And an example of something that gives you vesicles would be chickenpox. An example of something that gives you bullae would be impetigo, so that's Staph aureus. And some example causes of macular papular rashes. Often these are sort of viral illnesses, like I was saying, or could be something immune mediated. So examples could be measles, excuse me, rubella, um, erythema infectiosum. We would call that slapped cheek or parvovirus. It's where you get really, really red cheeks during the illness. Roseola, which you can see here. Lyme disease could give you a maculopapular rash. Pityriasis, which is a fungal rash you can see in the bottom corner here. And then drug-related rashes, like here you can see sort of raised itchy rash, erythema multiforme or Giannotti-Crosty syndrome, which is kind of what can occur with particular viruses such as Epstein-Barr, Entero, and RSV, respiratory syncytial virus. You can sometimes have this raised itchy papules post-infection. And then causes of lots of erythema and then peeling of the skin. That could be things like scarlet fever, so group A strep, toxic shock, which can be staph or staphylococcal scalded skin, where you get these raised areas and then peeling. Kawasaki disease, PIMS DS, that feels a little bit out of date now. This was a phenomenon that occurred post-COVID when COVID was first around, but it seemed to be something that happened the first time that you got COVID. And then otherwise, Stevens-Johnson syndrome or toxic epidermal necrolysis, which is a post-drug reaction. And then causes of vesicles or bully or pustules. Usually, again, these are infections and they're sort of an acute reaction in the tissue, or they could be sort of trauma or inflammation. And that would be things like chickenpox, so varicella zoster, Coxsackie virus, also known as hand, foot, and mouth, herpes zoster, so shingles, herpes simplex, so HSV. And often the first time you get HSV, you often get in children get really nasty lesions of around the mouth and in the mouth and on the tongue. Whereas once you've had it previously, often you will get cold sores instead. And this erythema toxicum, which is the pustular rash I was talking about in newborn babies, and disseminated gonococcal disease could also give you a sort of pustular rash, but the most likely thing that you'll probably see is a really nasty neonatal conjunctivitis. So I've just put a picture of that there instead. So let's do an example case if we can. So David's a 3-year-old boy who's brought to the emergency department by his mum with 2-day histories of rash, fever and decreased oral intake. His older brother has got a rash and similar illness, and mum says there was an outbreak of chickenpox at the older brother's school. When you examine him, you notice a miserable child who's got a widespread vesicular rash. Can you think of any differentials for this sort of vesicular rash, anything that we've mentioned before that could give you a similar rash? I wonder if I can unshare to look at the
HPV.
Oh, HSV, yeah. Fantastic. That would be one of my top differentials. That's fantastic.
And
And I didn't catch, someone said something else as well. I didn't quite catch that one. Oh, I still didn't quite catch that one. What I was thinking about otherwise might be, so we've got HSV or zoster, so shingles, or hand, foot, and mouth. You
I
get
was
really
saying Coxsackie virus. I'm sorry.
Coxsackie.
Oops.
Oh, perfect, brilliant. That was clear. I think you must have, the microphone was a little bit muffled, but that was crystal clear. Fantastic.
Yeah, thank you.
So yeah, absolutely, that would be one of my top differentials to give you such a widespread rash. So brilliant. Or impetigo, so staph, can give you quite a widespread spotty rash. Does anyone know what the incubation period of chickenpox is?
I think maybe wrong. I think it's 7 days.
Very
Five.
close,
5
but
to 7.
a little bit higher. So
It's 10 days.
10 to 21. Although if you are an immunocompromised contact of someone who's had chickenpox, we give you prophylaxis from 7 days because we know that you're likely to start, the virus is starting replicating by this point. So officially 10 to 21 days, but yes, something will be happening by 7 days. And when you're infective from the reason that it spreads so rapidly and so easily is that you're actually infected from a couple of days before the rash appears. So you can be wandering around spreading chickenpox without realizing, and then you're infective until all your lesions have crusted. So both your respiratory droplets and the skin lesions have virus in them, which is able to infect other people. And I think your idea of 5 days, that might have come from usually about 5 days after the rash has started. You get to see crusting, and then hopefully after those five or maybe 5 to 10 days, you stop being infectious. And it's so infective that if you're not immune to the virus, you've probably got a 70 to 80% chance of being infected with the virus if you're exposed to someone with early chickenpox. And in the UK, at least about 90, we don't have the vaccine yet, and about 90% of people have had chickenpox by the time they're a teenager, so it's really, really widespread. And usually the rash starts on your face, chest and back, and then spreads outwards to your limbs. Are there any investigations that are necessary for if you think someone has got chickenpox? I agree with your silence. Mostly none. It's a sort of clinical diagnosis, and hopefully that people with chickenpox can be managed at home. The only caveat that I would say is that children who are still spiking temperatures over 4 days after the rash has appeared, that should make you worried that they may have a complication. So, particularly group A strep sepsis can occur post chickenpox. People can get a really nasty skin and soft tissue infection with infected spots acting as the sort of portal of entry for the bacteria. So if you do see a child who's febrile after 4 days of chickenpox, you really want to examine them carefully, look for any evidence of cellulitis, and think about whether you need to do any x-rays or bloods. Can you think of any other complications of chickenpox or other things that you can get while you have your chickenpox?
Maybe herpes zoster, of the ophthalmicus, and
Yes. Yeah.
maybe also in the long term there may be shingles. Yeah,
Yes, exactly. Yep. Yeah,
and
unfortunately,
post-herpetic
once
neuralgia.
neurological, did you say? I
Post-herpetic neuralgia.
Neuralgia, sorry, yes. Yeah, so unfortunately, once you've had chickenpox, you then could be prone to having reactivation and having shingles. So, chickenpox isn't necessarily the only thing that's going to happen to you. Like you say, you could later get shingles, you could get the post-herpetic neuralgia. So lots of, um, and you could get zoster in, yes, as you say, in the ophthalmic region. So lots of post-chickenpox issues could occur. And even with the acute infection, we've talked about skin and soft tissue infections, but we can also see otitis media, we could see pneumonia, even encephalitis. We've seen some children with that. And particularly if you're immunocompromised, you could get really severe disseminated infection, including DIC. We also see an unusual complication, so post-infection. So after you've recovered from the initial chickenpox, some children develop a cerebellar ataxia, usually sort of 2 to 4 year olds, and it will resolve spontaneously and the child is well, but they have these sort of motor abnormalities. It's probably one in 300,000 children that occurs in. And Guillain-Barré could occur post chickenpox, but it's quite rare. Interestingly, the older you are, the worse your chickenpox is. So it's much worse to have it as an adolescent than it is to have as a younger child. And we do sometimes give acyclovir to older children if they develop chickenpox to try and prevent severe disease. For David, for our 3-year-old, are you going to give him any treatment? And if so, what might you give to him?
I think it's a conservative treatment.
Yeah, fantastic. I agree. So you might give something to try and manage the itch. So maybe some antihistamines or some sort of soothing lotion, paracetamol if there's a fever. And we wouldn't standardly give any antiviral medications, but sometimes in older children we might think about doing that. So fantastic. I don't know, have you ever heard anything about using NSAIDs such as ibuprofen during chickenpox? This is a bit of a debate that sometimes is had around people with chickenpox. But there is some suggestion that if you use NSAIDs, that you may be more likely to see an invasive group A strep complication, so a skin and soft tissue infection. And this has been something sort of throughout the last 20, 30 years that people have been wondering about. And what someone found basically when they looked through all the literature about this was that I think perhaps it's more the case that those children who are so unwell with their chickenpox that they're needing, ibuprofen rather than just paracetamol to help control their fever might have bad disease who might be more likely to get complications rather than that ibuprofen causes skin and soft tissue injuries, skin and soft tissue infections. So the absolute risk of having ibuprofen and having an invasive infection was really, really low. Although our guidance in the UK is still to avoid where possible due to this doubt. Are you familiar with the idea of giving anti-chickenpox immunoglobulins to people? Is that something that you've come across in your practice so far?
I think for pregnant
Yeah, fantastic.
and also maybe for the fetus, the
Yeah,
neonate, because
yeah,
it can cause
yeah.
congenital varicella syndrome.
Yes, yeah, absolutely. So we really worry about those babies who are born to mums who have chickenpox. Two options. So they could have it during pregnancy and have the congenital varicella syndrome, or they could have it right at the end of pregnancy and mum is unwell with chickenpox, but then transmits to baby who doesn't have any antibodies because mum hasn't yet had the opportunity to make any antibodies. So then baby could really be quite unwell. So for our guidance in the UK of who we would give antivaricella immunoglobulin to would be people who's had a significant exposure. So that would be even a significant exposure is sort of 15 minutes in the same room. So really, you don't have to have that much contact to be at risk of chickenpox. And then a condition that increases your risk of severe varicella. So this could be oncology patients, neonates, and pregnant women, and no antibodies to varicella virus. So you could hopefully check antibodies in older in pregnant women to try and establish this. So and as we were saying before, you can give your prophylaxis up to 7 days after contact if it's let's say a pregnant woman who's been into contact with someone at nursery who's got chickenpox. You can, because the incubation period is so long, you could manage, if you manage to get the antibodies in within 7 days, you'd be happy about that because she's not instantly going to become unwell. The other thing that we do sometimes do now, because varicella immunoglobulin is really hard to come by, is in pregnant women or in oncology patients, we can use acyclovir as prophylaxis instead of the immunoglobulin. And that's been shown in sort of older populations to be equally as effective as the immunoglobulin. But we know that newborn varicella's got about 30% mortality rate, so those are the people that we really, really want to get our immunoglobulins into. And I might skip through these questions because these are really very specific to chickenpox, but if we often get questions around what do we do if this person has had chickenpox and then they've got a contact at home. So generally, if it's the contact as a baby, we want to know if mum has had chickenpox. So if mum has got antibodies, we know that they'll pass to baby and baby would be relatively protected, but we would have a low threshold for treating baby if we were worried. And other queries that you might get, let's say someone is pregnant and is in contact with chickenpox. We need to organise antibody testing to see if they've had chickenpox or not. If they haven't, we would give them acyclovir. And if this is someone who's regularly coming into contact with children, we want to think about immunisation, but we can't give immunisation during pregnancy because it's a live vaccine, so we can't do that. And I guess you very smartly mentioned this already. So the reason that we worry about the fetus is that there is a risk of congenital varicella syndrome if mum gets chickenpox earlier on during pregnancy. So if it occurs before 20 weeks of gestation, the actual incidence is pretty low, but the consequences are a lot more devastating. So you could get microcephaly, cataracts, intrauterine growth restriction and scarring of the skin, and there is a high mortality rate. If the infection to mum happens later on in pregnancy, you might actually get a baby who can have shingles later on in life, but a healthy baby. It's really the worry if the the chickenpox occurs right around the time of delivery. And the risk is also really to mum as well if it happens in the late second and third trimester, because this is the point at which mum's immune system is kind of reaching its lowest point, and so that she doesn't reject the fetus, but is also therefore at really high risk of viral infection. So this is why things like COVID, flu, chickenpox, we would really worry about mums getting at that point. If you have a few more minutes, we could do another case.
Yeah, we can. But
Yeah.
can I ask you a question, Doctor, please?
Yeah, of course.
Yeah. When to give the pregnant women? Are any pregnant women should be given the vaccine?
So I would suggest if it's we can't give it during pregnancy because it's a live vaccine, so it could cause infection in mum. But if this is a woman who's, let's say she works in childcare or works in a school or works somewhere that she's likely to have contact with children, and therefore be at risk of contracting chickenpox, I would suggest, if she doesn't get chickenpox from this contact now, that she would get vaccinated when she's no longer pregnant. So if you're pregnant, you've not had chickenpox and you're exposed, we would probably give you a cycle of prophylaxis. And if you don't get chickenpox, you'd suggest you get a vaccine when you're no longer pregnant.
So it should be given before getting pregnant.
Ideally, yes. I'm not. I mean, as I say, most people in the UK, about 90% of people have already had chickenpox by the time they're adolescents. So it's probably a relatively rare scenario that someone who hasn't had chickenpox is in contact with it while they're pregnant. But if you are someone who works with children and you're thinking about getting pregnant, it would probably be a good idea to have a vaccination.
Okay, thank you.
So next case is a 5-year-old boy who comes to the ED having been unwell for 3 days, started with fever, then headache and sore throat, and then a rash appeared 24 hours ago. And the way that the rash appeared, it started on his abdomen and then spread to his neck and arms and legs, and it feels rough to touch. What you see examining him is kind of what you see in the picture here. So a sandpapery looking rash on his trunk and on his limbs, which is particularly pronounced in sort of the flexures. So like, for example, in the elbows. What other symptoms might you have with a group A strep infection or scarlet fever?
Ear pain.
Yeah, absolutely. Have you heard of the idea of strawberry tongue? We would call it in the UK. It's where you get like a white coating on your tongue, and then this sort of peels off, leaving a sort of bobbly pattern on the tongue. May have a different name for it, but it looks essentially like a strawberry.
tongue?
Strawberry tongue, yeah. Exactly. So the other things that was someone else saying something? The other thing that you might see, quite specifically with group A strep, you might get sort of facial flushing, but really around your mouth stays very pale. And you might also see, let's say he has tonsillitis and scarlet fever, you might see some big cervical nodes. The other thing that group A strep causes is peeling of the extremities, but that usually happens 1 week down the line. And this is an example of the sandpapery rash and the strawberry tongue. So you can see it's sort of bubbly like a strawberry. And this is an example of the perioral pallor. So you can see this child's got really red cheeks, red face, but around the mouth has stayed really pale there. And so scarlet fever, we've established that it's caused by group A strep or strep pyogenes to give it its proper name. It's found on the skin or in the throat. Lots of people carry it, and it's usually about 20% of children colonized with group A strep at any one time. And often it doesn't cause them any trouble, but for example, post-viral infection, particularly post-flu or post-chickenpox, that colonization can turn into infection. And there are lots of different strains of group A strep, and some are a bit more virulent and likely to cause invasive disease than others. And this is related to the M protein, which is a surface protein. These virulent forms can also make super antigens, so particular toxins that can give you a really sort of the picture of sepsis. And the scarlet fever rash is another thing that can be caused by the toxins with group A strep. We also can see post-infectious complications, so rheumatic fever and post-strep glomerulonephritis are other complications of having a group A strep infection, which is untreated. Differential diagnoses for that sandpapery looking rash. I've got a few here. So for example, measles, Epstein-Barr virus, parvovirus, general viral rash, which I'm sure if you've seen children, they often just have a non-specific rash when they get a viral infection. Kawasaki disease, staph, toxic shock syndrome in someone who's unwell, or Stevens-Johnson syndrome. How do you confirm your group A strep diagnosis or your scarlet fever diagnosis? Do you need any investigations? You don't necessarily. So it could be usually a clinical diagnosis if you see someone with their sort of sore throat and then that specific sandpaper rash, that would be a clinical diagnosis. We don't routinely recommend doing throat swabs on everyone, although sometimes you have sort of periods of outbreaks of group A strep, and sort of public health advisory authorities might suggest doing that. There are also blood tests that you can do to look for previous group A strep infection, which we would have ASOT or anti-DNase B tests, which you might look at if someone comes to you with what you think is like the post-infectious complications. So someone comes to you with glomerulonephritis, or you think they've got rheumatic fever. And those peak post-infection, so the ASOT comes 2 to 4 weeks after infection, and then slowly goes back to normal. And this is we can test this because it's produced by almost all strains of Strep pyogenes, but can also be produced by other different streps, so it might not be the perfect test. And the anti-DNase B titer that goes up after both throat and skin infections, so that could be a helpful test for you. And it's a bit more specific. It's only produced by group A strep. And how do you treat someone with scarlet fever?
Antibiotics
Yeah, fantastic. So
for gram-positive bacteria.
yes,
Amoxicillin.
yeah, perfect. So yeah, something that would cover your gram positives. In my practice, we might use penicillin, or azithromycin if someone is allergic. But basically, whatever you can use that you have that's narrow spectrum and is going to cover your gram positives. For skin infections, for example, flucloxacillin is. I think that was what you mentioned is a really good antibiotic as well. And otherwise supportive treatment. So help with the fever, help with fluid intake. And you, with scarlet fever, for example, regardless of how unwell the child is, you want to speed their recovery and also reduce the risk of complications. So those post-strep complications, and also reduce them being infectious to other people. So yeah, and then in terms of group A strep is a pretty horrible bacteria, and it's quite amazing how many different things it can cause in terms of complications. We could categorize them by being suppurative, so pus-related complications, or non-suppurative, and it's a pretty epic list. So you can get otitis media, mastoiditis, sinusitis, abscesses, meningitis, endocarditis, retropharyngeal abscesses, invasive group A strep infections, and then the later complications. And usually that's in people who haven't received treatment. So that's why it's important to get in with our penicillin if we can. So post-strep glomerulonephritis or rheumatic fever. And that was just an example of erythema marginatum, which is a rash that can occur with rheumatic fever. And then the last question, in terms of transmission to other people, in our setting, we would suggest excluding the child from school until they've had 24 hours of antibiotics, because in fact they could be contagious for up to 2 weeks if they haven't been treated. So ideally get the antibiotics into them. And we also keep track of scarlet fever or invasive group A strep infections, because there are often outbreaks. And a couple of years ago, there was a really bad outbreak of group A strep where there was a lot of children with pleural effusions. So we sort of track that, and this is the sort of the Public Health Board for the UK that we would tell about this infection. I do have another case or two, so let me know what you're thinking. I know we've been going for a little while now, so if you would like to stop, I can send on the slides, or if you'd like to keep going, we can keep going. I don't want to overload you with too much information.
I prefer that we like stop or take a break. I don't know
Yeah,
about the
yeah, that's absolutely fine. I think that's a good idea. What I'll do is I will send. I think there was 2 more cases in this series, and they're other things that are rash related. So what I might do is I'll send those slides along. So maybe in your own time you can have a look through those if you're interested and want to do some more looking at sort of rash related cases. Would that be okay?
Yeah, okay. Thank you so much, Doctor. We appreciate your efforts.
Oh yeah, no problem at all. I'm very
Thank you
happy to
so
join.
much.
Sure.
Are those the slides that I already have?
No, I finished
Okay.
the meningitis one quite quickly, so we went on to talk about rashes. So
Oh,
I will
okay.
send over some rash related slides.
Okay. And then I've also got MCQs to send everyone. And I can do
Yes.
that.
Yeah.
I'll do that right now.
Oh, perfect. Brilliant.
Okay.
Thank you all very much for joining and for being involved. It was really great to have the discussion, and thank you for contributing. And I wish
All
you
right.
all the best.